character of interest here. So I first want to introduce you both. Dr. Lauren Natbony is a headache specialist and neurologist, and she is the founder and medical director of the Integrative Headache Center in New York. And Dr. Zac Spiritos is a neurogastroenterologist, and he is the founder of Ever Better Medicine in North Carolina. So I think, Dr. Spiritos, we want to start with you. And if you could tell our audience, explain the gut-brain axis in simple terms.
Simple terms, huh? Yeah, so I mean, it's the gut and the brain communicate a lot. And in the sense that our gut sends information to our brain about kind of what's going on there, pain signals, chemicals, nutrients, right, that dictate kind of our mood, our satiety, and then those signals get integrated in our brain, and then the brain will communicate then back to the gut via through nerves that directly impact not only how our intestines move, but also the local immune system in our intestines as well. And so it is this complex network of our nerves, our immune system that kind of and it creates this feedback loop between our gut and our brain that dictates not only how our gut moves, but how we feel it. In addition, that also affects our mood and our satiety, amongst many other things.
Okay, well, go ahead, Dr. Natbony. You just go for it.
I was just going to say it's complicated, and I think that is why there's so much information, misinformation, and it's hard to really put in simple terms. So I will echo exactly what has been said. It is this connection that's working in the background, and what I believe from a migraine perspective is part of the whole pathogenesis and really starts with the gut. And yeah.
Yeah, I mean, we see for those who have chronic GI conditions, for a subset of those folks, a lot of those patients, I mean, I'd say 70% of my patients are dealing with chronic migraines. And I think there's a lot of shared, it's tough to know whether like one drives the other. I think my interpretation is there's a lot of shared pathophysiology between the two. A lot of the I tend to deal with folks who have chronic GI conditions where the testing has been either unrevealing or points to something that doesn't account for people's symptoms. And when that happens, right, like by and large, people fit into like one of two buckets. One bucket is inflammation, right? So there's, albeit like endoscopically, everything looks okay, but there's like microscopic inflammation there that can drive a lot of symptoms. Or there are people that it's more of like kind of a nerve issue whereby the nerves communicating to the muscles of the gut that signal isn't propagated well for whatever reason. So people's intestines move too fast or too slow. And I tend to think that, I mean, correct me if I'm wrong, I'd love to pick your brain about kind of the pathophysiology of migraines, but I imagine when we talk about the former group, one category of cells we talk about is mast cells. And when we talk about people with like irritable bowel syndrome, which is like the least helpful description of people's symptoms ever, when they take a look at people's biopsies that have a lot of symptoms, specifically people with irritable bowel syndrome with diarrhea, we see a lot of mast cells in close proximity to nerves, and that seems to correlate with symptoms. And so the mast cells are playing some role here. And I find that when I treat people who have chronic GI symptoms who also seem to have that maybe due to mast cell disease, when I treat their mast cell disease, sometimes their headaches get better. Yeah. And I wonder like how much do mast cells play in the role of migraines? And but I imagine I'm just kind of blubbering on here, but like just like chronic GI conditions, like there's so much. Yeah. Like IBS is so heterogeneous, and I imagine migraines are the same. It's not just people who have mast cell disease. I'm sure it's a whole collection of folks.
Absolutely, and I think that is the complexity, is that there's so much variability. And I will say, I would gather to say 90% of my migraine patients have GI complaints. I feel like chronic nausea, constipation, diarrhea, IBS. And we know that during a migraine attack, we have gastroparesis. So the digestion slows. We also know that people can have diarrhea, they can have nausea, they can have vomiting. So it is all happening during the onset of a migraine and during the entire process. And with mast cells, I agree, because we know that histamine release, we know that that is part of the migraine pathophysiology and part of its generator. It's not the only thing, which is sort of, we say it's so much going on. But I also find that if I treat someone with a antihistamine, for example, it will help a subset of patients, not chronically, but for example, medications like periactin, cyproheptadine, like that does work for a subset of patients. Using Benadryl, diphenhydramine for rescue, we do add it to a lot of our treatments because it does help. It does help with that histaminergic release. And there are people who, for example, do well on a low histamine diet. So I do agree from that standpoint. It's not everyone, but I feel like there is that subset of patients that we should be looking at, because it is the mast cells, histamine is part of the whole picture.
One thing that I'm really curious about is, and I don't know a darn thing about migraines. Like I think I read like up to date,
But
right? At
I'm
one
here.
point in
I'm
time, like
here.
that's it. So I want to be very clear. Like, I know not a whole heck of a lot about this. I do people on CGRP medications all the time because I just think they work really well. But that's a different. I'd love to talk to you about that. Like when is actually
Agreed.
appropriate as a
Next
GI
time.
doctor treat migraines. But
I'm
you know,
happy you do that. By the way, I'm happy because
oh, it's the
everyone's
best. Like, what are we
different.
doing? They're the like.
I
I don't want
know.
to use
What
triptans. I'm not using chronic endomethacin. Like, what as a protector of the GI tract, I cannot put people on chronic endomethacin. And triptans are like, I don't know, like they don't. I don't think they
No,
work very
thank you.
well.
Everyone
Right?
with iron
What are
deficiency
we
anemia,
doing?
because they're on chronic NSAIDs or whatever. I'm all about protecting the GI. So yes, you asked
Yeah,
me
yeah.
all of your migraine questions.
Yeah, yeah. And so I do find that a lot of my patients, and I treat a lot of dysautonomia, a lot of motility. I do see a lot of patients with mast cell induced GI dysfunction, um, and I do find that I see a lot of these patients have vertiginous migraines. And I don't know if that's like unique to the MCAS patient population, and what is that like when someone has vertebral migraines? Does it say something about the underlying pathophysiology of what's going on? And I'd love to hear like why that happens.
It's a great question. And I think vestibular migraine is still in our appendix of our classification of headache disorders. But the vestibular system is greatly intertwined with the brain. As we know, the vestibular ocular reflex, I find a lot of patients who have a lot of light sensitivity, who have a lot of trouble with sort of visual focus, have a lot of issues with their feedback to their vestibular system. And we know that any sense of movement can be part of the vestibular migraine syndrome. That being said, to have vestibular migraine, you have to have a diagnosis of migraine, which I think is the biggest fallacy out there. Someone who has never had migraine cannot by definition have vestibular migraine. Per definition, again, everything is a sort of, there are exceptions to the rule. But vestibular migraine, I find, is also really complex when you have orthostatic intolerance. What is vestibular versus the orthostatic component? And that's actually where I have the most difficulty trying to tease it apart in my patient population, because we know that vestibular symptoms don't have to be room spinning. It doesn't have to be vertiginous. It could be lightheaded. It could be like you're feeling like you're rocking. It can be feeling like you just are out of it. I feel like a lot of patients say, I just don't feel right. I just feel off. And that is a lot of that vestibular input, which I find is a huge part of migraine, and not only with the headache, but without it. And then you complicate it with the orthostatic symptoms of POTS, and you take that together, and trying to treat both those at the same time is really complex, and it requires overlap. And I also say GI plays a role in that too, because a lot of my patients will say that they feel more dizzy with eating or without eating, or when there's something with the gut that plays into it. Do you see that?
The migraines come and go with
But the
what they eat.
dizziness, no, that
Oh,
patients who
dizzy.
are feeling dizzy, when you see it in your dysautonomia patients, outside of migraines, you see a component with GI.
Ooh, yeah. Dizziness is complex. When I think of like orthostatic intolerance, I does it happen when they eat? I think sometimes. I think sometimes. And then you always think of like splanchnic pooling, like if they
Yep.
eat like a lot of like a carb heavy meal. which tends to, it just takes, like when you eat carbs, they get digested really, really quickly. And so people need, like your body diverts a lot of blood flow to your proximal small bowel to absorb all that, those rapidly, like carbs empty from your stomach like really, really quickly as opposed to something very fibrous or fatty. And so your blood rushes to your proximal duodenum to like scoop up all those carbohydrates. So it sucks a lot of blood volume into your abdomen. And in someone who is already predisposed to kind of dysautonomia, where blood isn't going to the right place at the right time, that can in turn lead to dizziness. I do find more often than not that it's due to like just blood pooling in the pelvis and the legs when standing up, and when people like really dehydrated, like first thing in the morning. But it brings me to like a great something that's been like a mystery to me is, we also see a lot of migraines in those with POTS, right? And is it due to cerebral hypoperfusion, or is it due to sympathetic overdrive? Because we know that people with POTS live in sympathetic overactivity. And just to bring it full circle, right? When people have acute migraines, their whole GI system shuts down. They get acute gastroparesis. And that's, in my opinion, probably due to overactive sympathetic overdrive, where you're in fight or flight and your parasympathetic arm shuts down, which is your rest and digest. And that leads me to another question. Is that why propranolol works, right? For migraine prevention. I just put a lot on your plate.
A lot.
You
Okay.
have 35
I'm
minutes.
gonna take this. I'm gonna take this one step at a time.
Yeah,
So
sorry.
with my brain just trying
These
to
are all
focus on the first. Okay. So circle back to me the first question there.
okay. The first question, okay, is was Friday afternoon, guys. So the first question is in someone who has dysautonomia, right? And dysautonomia is a broad category of neurologic dysfunction, but specifically POTS, which is postural orthostatic tachycardia syndrome. We see a lot of migraines in these folks. Do you think it's due to cerebral hypoperfusion,
Yeah.
where there's not enough blood going to the brain because it's sitting independent area of
Got
the
it.
body, or is it just sympathetic overdrive?
Thank you for clarifying that. I feel like my Friday brain just sort of
Yeah.
sort of
I'm also,
well, yes,
I feel super ADD right now, so I
me
just.
too. But I love that question because that is the question I ask myself all the time. This is what I like to talk about and what I lecture about is that migraine, when it's comorbid with POTS, is most often the hyperadrenergic variety, which is what you were saying, that sympathetic overdrive. But there is also, we know there is a component of cerebral hyperfusion. So I think it's both. I do think it's both. I think there is some where it may be one more than the other, but I have to believe that they both interplay. But where I think that we also know that with propranolol, getting to that question, it doesn't work for everyone. And I feel like a lot of my
Right.
migraine and POTS patients, it is actually not the best tolerated or the most advantageous. I tend to find that nebivolol, bisoprolol, those tend to work better. Is it because they have that peripheral vasodilatation aspect? I don't know, but propranolol tends to make my patients tired, and it doesn't help as much with that migraine subset. But what does help a lot is taking away anything that is bringing on that sympathetic overdrive
Right.
and really trying to calm that down and rebalance the parasympathetic. And then also increasing perfusion, because, right, we know our equation for cerebral perfusion pressure that it is a dynamic, and we have to sort of work on increasing what increases cerebral perfusion.
Yeah. Which brings me to another point is why propranolol would work, but Mestinon wouldn't work, which augments your parasympathetic tone.
Yep.
So maybe it's not that you need more parasympathetic tone, but there's too much sympathetic activity.
Yes.
And we know that there's a
Yes.
lot of sympathetic activity in these folks because, I mean, there's a couple of reasons for that. One is there's some subset of people that have this like hyperadrenergic type of POTS where norepinephrine, which is our adrenaline, cannot be cleared from this. Like, so you have one nerve that speaks to another nerve, and this is called the synaptic cleft. And there's when one nerve kind of communicates adrenaline to the other nerve, after it speaks to the other nerve and it communicates the adrenaline response, you should be able to clear the adrenaline from the synaptic cleft. But in POTS, we find that that may not work as well. Furthermore, that when people have a lot of blood pooling in their lower extremities and they're not getting enough blood to the brain's like, help, I need a lot of blood flow immediately. And that drives a lot of sympathetic overdrive. And I do wonder, yeah, like that may be, as opposed to like augmenting parasympathetic tone, it's probably just reducing the sympathetic tone that
Yeah.
really would work. But it's nuanced, right? Because if that's the case, then propranolol would work for everybody, or
Exactly.
guanfacine would work for everybody,
I
right? But
love guanfacine, but it doesn't, because I feel like
it
it's the
doesn't, right?
scales. I look at it as a Libra, like I'm always looking at like the scales and the balance is that you either have too much of one, too little of another, or maybe they're just out of whack. So that's where I like to use Mestinon when I feel like, okay, I need to augment my parasympathetic tone, because that is what's the driver of things, not necessarily the overactive sympathetic, but it is such a balance, which is why it's complex, hard, it takes time, and it's not a one size fits all.
Yeah, and someone said that, how about if someone has complex migraines, hemiplegia with dysautonomia, CRPS, eosinophilic jaundice, celiac disease. So when someone has a bajillion things going on, right,
Every
which
patient,
is
yeah,
all of my patients, right?
first too.
And so you say, okay, so what's driving your migraines, for example? I tend to look at the most like the arm of their symptoms that is why they came to me today, right? Is it that you stand up and you get really uncomfortable and your heart races? Is it that your GI system just doesn't move, that your gastric emptying test shows that you retain everything? That's like, okay, well, dysautonomia is driving this person's kind of, they may have some hypermobility and mast cell disease, but dysautonomia is like driving a lot of what's going on here. Or is it someone that they can eat like two foods because they react to everything and they
Yeah.
get flushed and rashes and they're like, okay, well, this is more of like a mast cell picture. And so not saying, certainly both can coexist, but when someone says, what's driving my migraine? Like a lot of things in my world, migraine is not something where there's a data point to say like, this is what's driving it. A lot of it's, I'm sure Laura's the same, but we listen to your story to see what potentially is driving it. And sometimes you miss, right? And you whiff, but you start peeling back the layers of the onion, like, well, it may be this, so I'm going to try this, and then I'm going to test this theory. But actually brings me back to a thought that I have all the time is when all else fails, use a CGRP.
I
And
was
I'd
just
love
going
to
to say,
hear,
that was just what I was going to say.
right, is that the common, can you break down, like I've read about migraines, I kind of think I understand how CGRP kind of factors into all this, but can you break it down to like migraine 101, like why CGRPs work, like who's it a good, who's a good candidate for this, or is it just everybody? And maybe drop a little knowledge on us about that.
Yeah, so this is what I say to my patients. CGRP is an inflammatory neuropeptide. So it's something that's in the brain that's part of the migraine generator. I look at migraine as the generator and the transmission of you sort of start it off and then multiple things happen over a cascade to get to the actual migraine attack. And we know that CGRP is part of that, of the attack process, but we also know that people with migraine have elevated levels of CGRP, calcitonin gene-related peptide, even in between attacks. So that's also what we feel like leads to this central sensitization. Central sensitization is when the brain, I said, is on fire. Like I basically liken it to a fire. The brain is just burning and all these connections are going out of control and it can't be put out. And that is also what I see a lot in my patients who have autonomic dysfunction, is that there is what I believe is there is central sensitization going on. And because CGRP works to target, those medications work to target CGRP, it can help to reduce the overall sensitization of the brain, but it is not a cure because CGRP is only one of so many different chemicals and mechanisms that work in migraines. So it's not an absolute. I like it as part of my toolbox. So I feel like every patient should have treatment that targets multiple different receptors and different modalities, because if we're targeting only one, we're missing part of the picture. So if I look at it sort of as a hierarchy and my foundation is sort of down here, I think that most patients, again, not everyone, most would benefit from being on a CGRP medication to bring down that central sensitization. There are others that then I'll layer on that target more specifically the experience that they're having with migraine and their most bothersome symptoms. So that's where I look at, okay, migraine is genetic. We know it's genetic. Yes, there are environmental components, but if we take it as a genetic disease, why do some people go and have one migraine attack a year and others go and have daily headaches? There is something either internal, external that's playing a part. And that's where I try to dissect, is there an autonomic dysfunction? Is there something GI? What else is triggering that we can't see or that we don't understand? And then that's how I pick it apart.
Okay. So it sounds like the common denominator for most people with migraines, someone said that they tried a CGRP and it didn't work. So I'd love to come back to that later and say, what is that? Like, what doors in your brain does that open? So I
Yeah.
suppose that like, okay, so CGRP can just help with sensitization, which is kind of
It helped with
turning down the volume.
migraine, the whole pathway. Yeah, just turning it
Right.
down. And for some people, so there are some people who are super responders. So you give them an anti-CGRP, and I will say, because that is their chemical. I feel like we all,
Yep.
I think, are different. We can't measure who has too much CGRP relative, but I find that if it works for some people so well, great. Others, it does nothing, but it does nothing maybe until it's combined with something else that also synergistically augments its effect.
Right. So what are the other variables that you're looking at when CGRP is someone's a partial responder or a non, like, let's say partial responder? What are the other variables that you're looking at? And obviously it's patient dependent. You can just kind of list them off of inputs that you could theoretically target to say, okay, this is how we kind of turn down the migraine signal some more.
Yeah, so when I always look at CGRP and then I look at Botox actually as my foundation because Botox also casts a wide net. And then I'm looking at, are they more sympathetic overdrive? Because even if you don't have an autonomic dysfunction like POTS or something diagnosed, we know that migraine does have autonomic symptoms. Patients can have brain fog, they can have gut issues, they can have basically the whole like liking of all of autonomic symptoms without the orthostatic intolerance that gives you the basis of POTS. And I'm looking at, okay, are you one who is, and for example, someone who is so tired but can't sleep? I always look at the sleep part because if you're so amped up and it's the end of the day, you're exhausted, can't sleep, we have some sympathetic overdrive. How do I dampen that? Is that someone then that I'd want to layer on something like a propranolol or a beta blocker? Is this someone who also has chronic pain like fibromyalgia? Is it someone who we know has a dual input to this central sensitization? Is that someone maybe I'd want to put on an SNRI? So that again, that in a autonomic world might increase sympathetic overdrive, but maybe there are other drivers to this process. Then I look at it, okay, I sometimes use medications. I like memantine, Namenda, because I feel like, is there any NMDA? Like, is there, what other receptors are we not targeting? There's a strong subset of patients who respond really well to that. I then look at musculoskeletal inputs. Is there a neck pain component? Is there structurally some input that's coming from the neck, the shoulders? Either it's weak or it's tight, or you think it's tight when it's actually weak because you're hypermobile. Sort of what contributors is that having? And then how can we alleviate that, both with medication and with non-medication interventions? So it really is time getting to know someone. I tell my patients, I'm going to get to know you. And by knowing you and understanding what is driving your process, then I'll be able to intervene. So seeing patients frequently and understanding how they are responding to everything is really important.
I love all of that. If you have a headache, go see, because she thinks so critically about these things. Just by hearing her talk about this, she really wants to understand why you have a migraine as opposed to just putting you on a medication.
Thank you. And
And
yeah,
when it doesn't work, and I mean, I think we live in similar worlds where the objective data just fails us. I just don't have a
all the
lot of
time.
good, like I don't order a ton of data when you come to see me because by and large, it's just going to be more noise. But hearing your story, seeing what makes you better, what makes you worse, the context of your symptoms, that tells me everything. And sometimes we're wrong, right? We are not AI, we're not robots. We don't have like we have our own algorithms, but they're fallible. But we talk to people kind of like we keep in close touch to kind of peel back layers of the onions.
Exactly.
I'm fascinated by your approach.
I want
Um,
to hear yours. Wait, you have to tell me yours after
no,
that too. I want
yeah,
to
I
hear.
can't. No, that's just I'd have to kill you. No, it's very similar to yours. It's very like I talk to people a lot, right? And I think
Yeah.
I work really hard to try to understand why something happens, right? Like
Yeah.
I think of myself as doing my best to understand the neurology part of things, the GI part of things, and the immunology part of things. Am I an immunologist? No way. Am I a neurologist? No way. But I think I understand how the immune system interacts with the GI tract and the nervous system as well. So I take into consideration like who somebody is, how bendy they are, like what medications make them better, what foods make them feel crappy, and yeah, I use more of the story than anything else to dictate kind of what I do. And I just listen. Like that's my major tool is I listen because and I try to adjust the probability of something happening based on kind of who you are and how you got here. And so I just say, just talk. When's the last time you felt good? And take me from there. And that's kind of I've been in this game long enough to know that there's not incredible data points, right? Even the gastric emptying test is a really crappy data point. Like it can be totally abnormal and then normal the next week and then rapid the next week in someone who has dysautonomia, right? So when you have an inherent distrust in the data points, I mean, you interpret them in the context of who somebody is. But yeah, it's listening. But
Totally. And that's when when someone says my tryptase was normal and so I don't have MCAS, I'm like, no, it doesn't mean in that one split second in time, if you weren't having a flare, it's going to be normal. So we can't
yeah,
always take data. The data doesn't always support what we have to see clinically. And I think that's what as my role model, my mantra and yours is listen. I want to hear what you have to say because that informs everything.
Right. And also try to understand each data point that you
Yeah.
have. Like, what is the sensitivity of tryptase in mast cell activation syndrome? Is sure really, really good in systemic mastocytosis, but it's less than 10% in mast cell disease.
Yeah.
So it's understanding the tools that you have and understanding their limitations and strengths. I do want to get back to Botox
Yes.
because I'd love to know how that works in someone who's hypermobile and pretty wiggly. Do you have any considerations there? And who's the right person for this? Or is it kind of like, you know what, it covers so many bases that if someone is refractory to CGRP, I'm just going to use it because I just know it works.
So I love this. I actually just lectured about this at the American Headache Society conference that we were talking about. So you would think that Botox would be not great for people who are hypermobile, but actually it's the opposite. What Botox does is the doses that we use are small. So they're not necessarily muscle paralysis doses. For example, if you look at the trapezius muscle, we use 5 units spread over 3 sites. So it's 15 units. For actually dystonia or to actually like make the muscle a little bit weaker, go up 100. Like you need huge doses. So what we're doing is we're basically giving enough for pain relief. So for that Botox to go down to that junction, that neuromuscular junction, and basically stop overactive pain transmission. It's really cool how it works. I think we don't 100% understand, but we do know that it works peripherally, but then feeds back and centrally reduces that overactive pain transmission that is the driver of migraine. So if you take someone who is hypermobile and you're actually firstly bringing things down, toning things down, but I also believe that by reducing the tension on some of the overactive muscles that are guarding, it actually allows for strengthening of the muscles that are needed to protect the rest of the neck and spine. Because I think a lot of time, and correct me if you have a different experience, our hypermobile patients feel tight. They say, I feel tight. I feel like I have all these knots. It's pain, but the pain is actually due to the laxity, and we are not able to actually strengthen because we're guarded by the tightness. And I find that Botox really helps with that.
Interesting. And do you work with physical therapists to help strengthen other parts of because I certainly, when someone says I'm really, my world is down here. And so people have a
Right.
lot of a tight pelvic floor. And I find that it's kind of someone with hypermobility, you're tight up here and tight in the bottom. It's just kind of like, it's trying to hold it together because the connective
Mhm.
tissue is just lax everywhere. So
Yeah.
I use physical therapists a lot to kind of help with like core strengthening and also there's a lot of like mindfulness related methods that one can do to help relax the pelvic floor. But what's your when someone is
Same.
really, really active up there? Like, what do you involve physical therapists as well?
Yeah, you have to have a physical therapist to understand hypermobility. And I do have also a lot of patients with the same pelvic issue. So I do recommend also the pelvic floor abdominal strengthening. I do find that there is this connection, but you need to work with a physical therapist who understands how to appropriately strengthen because everyone wants to stretch. And stretching actually can activate pain receptors. It can make hypermobility worse. Even patients with migraine without hypermobility, I find that the stretch receptor reflex can really worsen things. So as much as we feel tight, the answer isn't always to stretch and loosen. It is to strengthen those muscles that are holding up our head. It's a long-term play. The problem is nobody wants the long-term play. They want that short-term relief, but that really is the long-term solution. So yes, in a nutshell, physical therapy is crucial, but the right physical therapy. And I think that's what's really the key.
Interesting. Okay, so to put a bow on it, Botox
Go.
diminishes pain, like
Transmission over transmission.
apparent pain transition. Okay,
Mhm.
excellent. And then, so I think we've touched on the nervous system. We've touched on the immunologic system, like very briefly. We can't discount the hormones in the endocrine system. So,
Talk
in
to me.
someone who has hormone-driven migraines, do you ever use like hormones in? Is that one of the tools in your toolbox as well?
It's a multifaceted question. So we know that with migraine, hormones play a role, but it's not that we have hormones, it's that the hormones fluctuate. So if you think about menstrual migraine, it's that, okay, you have this estrogen that rises and then it abruptly falls. So if someone has migraine around their period, either 2 days before or up to like 3 days after bleeding, then we can think, okay, is it this estrogen fall? In that case, continuous oral contraceptives that keep hormone levels stable can be helpful. I always first try to treat migraine as a whole,
Yeah,
but if all else fails, yes, stabilizing hormone levels can be helpful. It's all about the stability, more so than it is we have too much or have too little.
agreed. Agreed. The and if we're bringing it back to people with mast cell activation syndrome, it's the fluctuations in these hormones that really drive people crazy. Mast cells do not like changes in their immediate environment, and if you've seen people, the luteal phase, the end of the luteal phase tends to be pretty challenging when the withdrawal of progesterone happens. But yeah,
Yeah.
it is probably not hormones itself, but hormones, uh, but estrogen also can be, because hormones can certainly have an effect on mast cells, but they're vasoactive as well. Do you find that that plays a role too in terms of why people get migraines?
I think there's so many reasons. I would say yes. I think I could like look at all these different triggering factors, and I think it's all person dependent. And I feel like why is it then? I find that people who even are on, let's say, a Mirena IUD and don't get their period, they still are saying, I know that time of the month I'm going to get more migraine attacks, even though we know that there's really the hormone fluctuation isn't the same. So why is it? Is it just that endogenous estrogen, the endogenous hormones that we do have playing a role? I don't know. And I also have to believe they play a role in the GI system, in
Mhm.
the
Sure.
gut. And how do you address it in someone who has gut issues? Are you looking at hormones?
Yeah, I mean, in the context of like who somebody is. So like, if it's mast cell driven, then sometimes I do use hormone therapy. I mean, sparingly, like who wants a GI doctor like managing your hormones? Like no one is going to raise their hand about that. But in someone who has like incredible catamenial fluctuations to their symptoms, like goodness, I'm doing okay. And then like end of my like luteal phase, like I'm a disaster. That's when I'll like kick the tires on it in the context of like who somebody is. Like that has to starting hormone therapy is like a really big deal. And I'm often
Yeah.
talking to someone who's like in their 20s and like maybe trying soon, right? And it's a big decision.
Yeah.
And so that is when I will kick the tires on it. If someone also like perhaps doesn't want to be on traditional mast cell therapies, we do know that hormones have a big role on kind of smooth muscle contractions, right? So
Mhm.
progesterone seems to be rather relaxing, so people can get more constipated in the luteal phase. But I'm not like putting them on hormones for that. We'll just kind of
Yeah.
we'll work through their constipation for that reason. So I certainly like. I I understand its relationship with the GI tract, but it's not a button that I'm pressing routinely, unless there's like other reasons. I mean, someone
Yeah.
mentioned endometriosis, right? And so, I see a lot of my patients have
Me
endometriosis,
too.
and there's a lot of, there was a translational study that looked at like how mast cells in the endometrium really can kind of make some of these uterine cells shapeshift and kind of perhaps move outside of the uterus. So the question is like how how influential are mast cells in the evolution of endometriosis? I'm sure it's probably just really complex. Um, but yeah, so if someone also has like really heavy, painful periods, but also
Mhm.
symptom fluctuation with their periods as well, like then it's like a time that we should really discuss this.
I
But
agree.
yeah, it's patient to patient dependent.
But yeah, the overlap between all these conditions, endometriosis, I see a ton with migraine. Same thing you were saying, celiac, ton of overlap. A lot of inflammatory bowel disease. Like there is this huge overlap, and we know that patients who have those GI processes have more migraine and vice versa. So there has to be some driving factor. And I like your point about mast cells. I do think it ties it a lot of it together, but we're still trying to figure out how and what we do about it.
Yeah. Yeah, because we're pretty limited. It's still
Yeah.
kind of we're still duct taping it together. Like I'm losing low dose tirzepatide, right? Like which actually
Hmm.
someone's migraines went away with some tirzepatide the other day because I think it's all mast cell related, right? And so someone said in one of these messages, like, what happens if a CGRP doesn't work for migraines? And I'm going to give you my GI dumb brain approach to it. One is, are they really migraines, right? Like, is it something else? So we see a lot of headache conditions in folks with these comorbidities, specifically like a lot of issues with intracranial hyper or hypotension,
Yeah.
right? Like
Hmm.
leaks and things like that. So I'd be like, well, let's dive into like I think migraines probably get misappropriated all the time. Like, oh, it's a headache, it must be a
Yeah.
migraine. So I'd look at that, or is it just purely like a mast cell reaction, and isn't for whatever reason responding to a CGRP, and then you need to go down the mast cell route. But I'd love, Lauren, do you ever see like people with mast cell driven headaches not respond to CGRP, and you just need more mast cell therapy, like cyperheptadine, or how do you think about that?
I think that just separating it out is that CGRP therapy works for a subset of people. But if you look at the clinical trial data, it's about a 4 to 6 day a month reduction in pain.
Oh,
So I
wow.
also
Okay.
think it's not a cure, it's not
Yeah.
everything, but I also think we have to be framing as what does it mean for it to be working? Because I think a lot of people are looking at it, okay, I'm taking this, I should either have no migraine attacks or there should be this huge shift. And I think that that's also a problem with how we're
Right.
asking about benefit. So a lot of times I'm like, okay, you're saying it doesn't work. What does that mean? And then the patient will be like, I don't know, I just don't feel better. And then objectively going through, okay, maybe frequency doesn't go down, maybe severity went down. Some of studies looked at just improvement in quality of life. Was there a decreased disability? Are you more present at work versus absent from work? So I think when we're also looking at is something working, we have to define what working means to really know if it's having any impact. So that's always
Great
what I
question.
look at first. And I look at patients with chronic migraine tend to be the ones who are more challenging, but it's because CGRP, in my opinion, is not their prominent driver of their symptoms, or it's just a little part of it, or it's not involved in it. We know CGRP should be, but there are patients who it's just not. Also, there are different medications target different things. So we have the CGRP monoclonal antibody that targets the actual CGRP protein that's circulating. So you're basically binding to that protein and flushing it out so it can't bind to its receptor. We have ones that block the receptor in the periphery so the protein can't bind. And then we have the GPANs, which block the CGRP receptor in different areas and can work both acutely and for prevention. So the thing is it that maybe if we're just blocking the ligand, the circulating CGRP, there's just a lot of CGRP. We're not able to block all of it. I'm not sure. Is it if we're blocking the receptor and we know there are receptors in different places, are we just not addressing? I don't know. And those are sometimes in patients where, again, this is going to be totally off label, but sometimes combining a receptor antagonist and a
Okay.
one that targets the ligand together, I find
Yeah.
a lot more benefit. Again, I'm not saying to go do that. There are risk benefits of everything, but I find there is a subset of patients that I'm like, I really do think this is CGRP driven. We just have to approach it from different angles.
Awesome. Awesome. Can I ask something very selfishly?
Of course.
For cervicogenic headaches, what do you do? Is that a Botox? Is that the answer? And I
No.
just find that a lot of people like it starts here and then it just kind of works its way up and just does this thing. I'm like, I'm not sure it's a migraine, but I don't know if you've.
So as I sit here, like holding my neck, so the migraine nerves actually start at the C2, C3 vertebrae in the spine, and I look at it as it sends projections down to the neck, up, around. So neck pain is actually a prominent symptom in about 75% of patients with migraine.
Wow.
So we know it is part of migraine, and a lot of times patients feel it in their neck. So the differentiation between cervicogenic headache and migraine per
Potato,
textbook is
potato.
that cervicogenic headache should have a structural reason for it. There should be something structural that is causing it. And it's also a different quality of headache. But I will say that it often overlaps.
Yeah.
So most of my migraine patients have neck pain. And if neck pain is prominent, how are we working on the neck pain? Again, going back to physical therapy and strengthening, but also there is a role for using medications that help muscle relaxation. But it is, you have to tease
That's
it
it.
apart and see exactly. And I
Yeah.
think a lot of
I've
things are,
thrown. Yeah. I've thrown Flexeril at it, and I don't think it works very well. And for like, maybe I'm just also I don't have the ear that you have for like understanding
no,
and
but it's
teasing it. Mike, I'm
also,
like, you're
if you're
tight. Like,
having,
let's try some Flexeril. They're like, what do you stop it, man? So yeah, just it's a Hail Mary, but yeah.
no, it's the same thing when I'm like, when people are having a lot of gut issues and they're having a lot of nausea, I think that's the most, that's something that's really hard for me and my migraine patients. And even when they're not having headache, they're just always nauseous, a
Oh,
lot of nausea. And
I love nausea. That's my
please
favorite.
talk to me about nausea.
Oh gosh, it's my favorite topic of all time. I love dissecting nausea. I know I have one more thing for you first.
Yes,
I thought of it first, so I get to go first. We can
fair.
we can totally do nausea afterwards.
No, I'm
How
here.
often are you talking about diet? About like how often is that? Like, do you have like okay, we've talked about what this is. Like, is it now time to bring up what you eat? Do you ever bring that up in your conversations with patients?
Yeah, so when I look at actually evidence, which again, we say evidence is limited,
Yeah.
there isn't much evidence showing that diet is a huge part of it, but I believe that, but I don't. But I also don't want to blame patients that they're eating things that are triggering because it's really hard. Like changing your diet, I have to tell you, like I have food allergies in the family, and it's extremely challenging just to navigate a world where you're avoiding things. So I hate telling patients to avoid things. But looking at diet, if we look at the actual studies, there's some evidence for looking at the IgG and reactivity and sort of cutting things out. There's some role for altering your omega-3 omega-6 ratio. But what I tend to first do is I look at the frequency of eating, their eating patterns, and if they're pairing proteins with fats, with carbohydrates, sort of looking at maintaining stability. That's what I tend to look at first. But I do think there is a really strong need for someone in the nutrition space to come into the migraine space, because as one practitioner, it's a lot to try to go through and to alter someone's diet. And I always want to try to do it, but it seems like it's a lot to take on at one time. So first I look at stability, and then if I think, okay, I want to do a trial elimination diet, we will try. But like I said, it's hard, and the sort of output of it is variable, especially with chronic migraine. When you have headaches so frequently, what is a cause versus what's an association versus, it's really hard to tell.
I'm very tempted to launch into abdominal migraine and cyclic vomiting syndrome right now,
Yeah,
but I
talk
think
about that a little bit if
that's
you
a
could.
that's a 2 hour conversation.
Well,
Uh,
maybe just touch on it.
Touch on it.
Touch on it because it's very underdiagnosed in our community.
Yeah.
yeah, yeah. Okay, so let's talk about abdominal migraines. I think of these as very similar to migraines. Whereas cyclic vomiting syndrome, I think of more of seizures. Um, Abdominal migraines, man, they are episodic, right? Like they have a lot of similarities to traditional like kind of neurologic migraines. I guess these are neurologic as
They
well,
are, because they
right? They're
are the
neurologic. So it's
incipit
this
as a
is the
childhood precursor to migraine,
right,
abdominal migraine.
exactly,
Yep.
right? And so ciprofloxacin, oh, that's a different conversation of why ciprofloxacin may work for those things. But yeah, I mean it's they're stereotypic. There's a prodrome. They're like, it feels a little gnawy, a little crampy in my belly, and then whoa, it just kind of like it goes all over the place. Um, it is the quintessential disorder of the brain-gut interaction, right?
Yes.
I think it
Mhm.
starts centrally, like in the central nervous system, and then we feel it in our gut. I don't know why it happens. I don't know. I'm sure there's a genetic component to it. I think I think there's a channelopathy part of things where there's these channels that kind of dictate how nerves work. There's people that devote their whole life to channelopathies. I can't even start to understand it. But that's why medications like amitriptyline may work, which kind of just turns down the way that these nerves propagate their signals. So if someone comes in with like kind of really bad abdominal pain every couple weeks, there for about 8 to 12 hours, maybe some nausea, but just a lot of pain. Okay. Obviously, you need to go undergo all the tests, right? Make sure it's not your gallbladder. Make sure it's not your stomach. It's not an ulcer. But I got to say, there's not many things in medicine that cause stereotypic horrendous abdominal pain every couple weeks, right? So gallstones, I suppose, can do that, but it follows a very specific pattern. Like typically right upper quadrant pain, maybe to the middle, maybe to your back, and there's typically some gallstones or some sludge in there, right? But this is kind of pain that I suppose, could be in the right upper quadrant, but could be anywhere in the belly. There's usually a prodrome, meaning that your body starts to send you signals that something may be happening. You may smell something a little differently. You may feel a little more anxious. It could be in your GI tract. It could also be kind of a sensory issue as well, and it lasts for 10 to 12 hours, and then boom, it's gone. What drives it? I've typically found stress or sleep, sometimes diet like high histamines or high tyrosine foods. I like cured one guy's by putting him on. We like found he had really bad sleep apnea, and we put him on a CPAP, and they all went away. Um, I think of this as a migraine, and
It is. Well,
it's just a
abdominal
migraine. Yeah,
migraine,
it's
it's all migraine disease. So I think
right.
migraine, we think of as only a headache. It's not.
Right, exactly. It's a nerve conduction issue. And so I actually had a guy, I don't know if he's listening or not, but a guy a couple weeks ago, he was so determined to figure out what this is. When he had an attack, he went to an open MRI machine when he was having an attack, which is a wild thing to do, to be in that much pain and be like, I'm gonna go get an MRI right now. And he was able to do the breath holding and everything. And all of his stomach was bigger, his gallbladder was bigger, and he was like, oh, this must be his gallbladder. No, it was in acute migraine, his GI tract just shuts down, right? So everything just, it looks like functional stomach, functional gallbladder disease, but everything just shuts down and slows down. So in migraines, your whole GI system, like, you get like acute gastroparesis, right? Okay, so
And then do you treat with triptans? Because that's for abdominal migraine, treating with triptans. for a lot of patients works because it is all migraine. It's the same pathophysiology just manifesting elsewhere. So I
Yeah.
look at it, it's all the same disease process.
I don't usually do that. I should probably because you're here, and I'm gonna write it down after. It's like it's on my list of things to do. I usually abort it. Like so, I use amitriptyline prophylaxis, which I find works. So Elavil, I
Yeah.
find it works really well as prophylaxis. And I started like 10 milligrams and work my way up. But I really try to find triggers. Like, is it hormones? Is it sleep? Is it stress? Because that's and sometimes we don't find it, right? But it's always
Exactly.
it's a worthwhile conversation. And diet, I try to look at. Oh my gosh. Oh my gosh, do you guys hear that?
Sounds like my boys killing each other.
Yeah, I have, I think, yeah. Um, so yeah, I make sure that people don't fast. So fasting can make this worse. Do a dietary, so eat at 3 meals a day. Do a kind of a symptom. Try to um, give me 1 second, okay, guys. Sorry.
Okay. As we
Can
go, I
you
wanted to shout out to Dina in the chat saying, yes, it's all migraine disease. This is what we're talking about. It's all migraine disease, and we're doing lifestyle modification and trigger identification. Great, but it is still part of the disease process.
Yes, sorry. So a very detailed diary of why, like how kind of how this happened, why this happened. So we'll see if we can mitigate that, and then I'll like usually layer in medications like amitriptyline to prevent it. As an abortant, I usually use Ativan.
Wow, interesting.
I think it's just the way I was taught, and it seems that it worked pretty well. But I'll certainly like I think triptans would probably be something
Or
else.
a G-PANs, try a G-PAN, try
Yeah.
a trip. I think that again, each their own, but I find giving a good rescue treatment for migraine in general is comforting. So yeah, just more tools in our toolbox.
Exactly, exactly. Cyclic vomiting syndrome is a little bit different. So it's similar to migraines, abdominal migraines, in the sense that it's like stereotypic. It's usually like happens predictably every couple weeks, or there's a specific trigger behind it. Except it causes a lot of nausea and vomiting. And this nausea and vomiting is not like, oh, I feel a little queasy for a couple hours, like I ate too much Chipotle. It's like 2 to 7 days worth of horrendous nausea and vomiting. So most of the time people are hospitalized. Some people have been living it forever, like find their own remedies to like figure it out at home, but it's profound. Um, there can be some abdominal pain as well. Um, and yeah, it needs to be, it's categorically different than cannabinoid hyperemesis syndrome, which is people who smoke a ton of marijuana, like they smoke every day, and then they have kind of similar episodes as well. And that's kind of a different conversation. But
We
cyclic
need to
vomiting
have that
syndrome,
conversation at another time, by the way. So circling back
yes.
to my
Yeah.
list.
And it isn't like it isn't you smoke people smoke a joint every couple of days. It's like people who smoke 2 or 3 times a day. And so some people when they go to the ED and they have cyclic vomiting syndrome, they just happen to smoke weed every so often because it makes them feel better. They get mislabeled as cannabinoid hyperemesis syndrome, but really they have to be smoking quite a bit of marijuana for this to be CHS. But cyclic vomiting syndrome, I think of it more of a seizure than anything else. Um, and and it is yeah, there's not a lot of things in medicine that do this.
It
I
is
think
migraine. So it's still under the umbrella in my
still not
book
crazy.
because it's a childhood precursor of migraine. So we know it's still part of
Interesting.
the same pathophysiology. So
Okay.
if patients have had cyclic vomiting syndrome when they're younger, and then I'm like, you're at a greater risk for developing migraine, or they can come together, but it is part of
The
this
whole
whole
thing.
migraines. I look at syndrome. So
Yeah.
yeah, we're
What's
seeing similar
interesting,
things just in different body parts.
100%. Yeah. I mean, it's all neuroimmune.
Yeah.
Like it's kind of all neuroimmune.
Yeah.
And I channelopathy kind of stuff. And I will people respond more to mitochondrial supplements though in cyclic vomiting syndrome as opposed to abdominal migraines. So there's data for like coenzyme Q and L-carnitine. So
Mhm.
I pepper that into my regimen as well, which I don't think the data is as robust or even exists for abdominal migraines. I have to double check myself, but that's part of my toolbox for people with cyclic vomiting syndrome.
And
I use
I
similar
like that.
tools like amitriptyline, Topamax, Amend if need be, and then I'll use like Benadryl and Ativan for abortion agents. I don't use triptan. I don't find for cyclic vomiting syndrome, triptans are
Yeah.
as effective. They may be more effective for abdominal migraine where I haven't used them as much, but for cyclic vomiting, I've used triptans several times. I don't find them to be super effective there, but you know.
Yeah.
So yeah.
Oh, and then what is your go-to for nausea? Like I want to go back to the nausea question because I think a lot of patients, migraine or no migraine, have nausea. And what do you do? That's a
Yeah.
hugely loaded question. It's like you could
Yeah.
spend the rest of your life telling me.
Yeah, there's so many different antiemetics, right? I think it just
Yeah,
depends on like what's driving it. And so,
yeah.
postprandial nausea is different. So nausea after eating, right? That could be gastroparesis. That could be constipation. I mean, rarely constipation, but chronic debilitating nausea is different. Um, and there's a lot of different inputs there. So if there's like comorbid mast cell activation syndrome, like symptoms that play, then there's roles for like cyproheptadine. And amongst other medications too. And then there is one phenotype of people who wake up really, really nauseous who are not pregnant. And that's a unique, I haven't figured out like why that happens, but they respond really well to a medication called mirtazapine. That is essentially both has like antihistaminergic and anti-serotonergic properties.
I have.
Um, it's a good one. It's a good one. And so that early morning nausea that kind of dissipates by the mid morning, I usually think of it as someone who like for some reason can't tolerate the morning cortisol. Like it's just too much for me. I feel like so revved up. But like that's all conjecture.
I'm
That's not
totally a believer in the hormonal variations throughout the day. And
yeah.
I also believe that there is that generator of that early morning, 'cause it's migraine too. You have that early morning migraine attack. That is the generator. There is something to do with these hormonal cycles throughout the day and night. So
Yeah.
I'm,
So Laylee Pop said nausea that occurs in the evenings chronically. So that doesn't ring any bells to me. That doesn't fit one specific condition, but I'd say like, okay, so how long has this been going on for? Like, when's the last time you weren't nauseous? Does it have any variations around your hormonal cycle? Are you having any other symptoms while you have nausea? What has worked for you in the past? What hasn't worked for you in the past? And that's kind of how I whittle this down to figure out what's going on. Sometimes we just don't know, right? And
yeah,
sometimes it's just so I have one young woman who has like like an inborn mitochondrial deficiency, and she is nauseous all day, every day. And I don't have any idea why. I just can't figure it out. And there's medications like a aprepitant called a Mend,
Mhm.
right? That just works for everything. It's like the CGRP for migraines. It just works. And it's like the final pathway of nausea, which is the neurokinin 1 pathway. And that seems to be like when nothing else works, go to a Mend. It's really tough to get to insurance, and that's kind of a different beast. But there's a lot of tools, and sometimes I just cycle through them, but I try to understand the context with which you're nauseous. Is it a new medication, right? Are you like really stressed and not sleeping well, right? Is it morning nausea? Is it afternoon nausea? Like there's just so much. I just ask a lot of questions. If it's like anxiety driven, like will a low dose benzodiazepine help? Like there's so many ways to go about doing this. And just understanding like what tools that you have in your armamentarium. But I think it's just listening and just trying different things and listen and trusting your patients and believing them.
Believing,
Um,
huge one.
and
That
it's
patients, they're telling us, they're giving us the information. It's our job to listen and interpret it with the knowledge that we have. And I think a lot of times we don't, as I mean, I'm not saying this blanketly, but I think that it's hard. It takes a lot of time to listen. And our medical system, usually it's time that doesn't get to be had. So we
we're
see
we're
you,
beholden
everyone
to
out
data.
there.
We're beholden to data points too much.
Yeah.
And look, if you have a heart attack, if you have a stroke, if you have a broken bone, data points are really helpful. In the world of chronic invisible conditions, data points are not very reliable. They just aren't. They're pieces of the puzzle, but they are not very reliable
Yeah.
for the most part. And so a lot of times, as you mentioned, it's kind of finding someone that understands pathophysiology. I think Laura and I both really, really work our butts off to understand what's driving people's symptoms and then piecing your story with it and then using other data points like as ancillary but not the thing. It's not like there's not one thing that aha like that's exactly what it is. It's I listen for someone for 30 minutes. I'm like, I think I know what's going on because I like to listen to stories. And
Yeah.
you listen to enough stories, you start to build pretty strong, it becomes a pretty strong diagnostic weapon.
I wonder if my migraine patients, like I said, like 90% with GI, had you on the other side and we put that together, I feel like there could be a whole new world of patients feeling better. So I'm like so much loving this conversation because I'm like, I know the brain, I know migraine that happens with GI, but you treat it from another vantage point. And I think we need every vantage point sometimes. We need to see it from
Yeah,
all these different angles.
absolutely. I wish I could ping you all day, man.
I know. I feel like
Yeah.
my text would blow up. Like, what about this? What about this?
So someone said suggestions on calming the autonomic nervous system, which is
Like that.
I like. I mean, it's a beautiful question. It has a complex answer. I think whatever works for you, right? So I love like my early morning workouts, and that really like I need good
Me
sleep.
too. Me too.
I need my cup of coffee, and I like working out 4 in the morning, and I'm good for the day. If I don't do that, I'm like less patient. Like I just know that I'm a little bit more stressed. But there are protocols that like some people like hypnosis, some people like cognitive behavioral therapy, some people like limbic retraining, which I've used a lot of. I've shunted a lot of people towards limbic reprocessing, which are kind of programs that kind of when people have in a lot of patients that I see have been dealing with chronic invisible symptoms for a long time, and when you have these symptoms that have been ill explained and have such a profound impact on quality of life, when you have these symptoms, there are natural thoughts that come with these symptoms, like, oh shit, not again. Or is this going to ruin my day? Like, how
Yep.
long is this going to go on for? Am I going to be able to have kids? If I do have kids, can I play with them? And that begets more stress and anxiety that makes symptoms worse, right? And so there's these programs out there that kind of help kind of untangle some of those, not create like healthier thought processes, because these are very natural thought processes around symptoms, but it's like, how can we kind of perhaps not allow these symptoms to cause someone to spiral and make things worse?
Radical acceptance.
There you
Radical acceptance. There
Love
is
it.
radical acceptance, but there's also, I
Mm.
believe, in retraining the brain to think in a different way. And I feel like sometimes we train our brains in positive ways. Sometimes there's negative ways. How can we teach it? Brain learns, right? It adapts. The nervous system, it can feed back on itself. So to your point, I think that that's a great tool. Breathing. So I feel like I never knew how important breathing was. I
Oh,
mean, we all
breathing is
breathe.
so,
But I
yeah.
feel like I was like, I don't breathe correctly. I had to learn how to breathe. So simple things like that. We know that breathing, certain breathing techniques, like box breathing, can help regulate autonomic tone.
Someone said IVIG as well, and it's a tool like everything else. This is
Yeah.
sorry, I wanted
No, I'm
to,
looking to radical acceptance. I really
that,
truly believe. Thank you.
yeah,
It is true.
right,
Radical acceptance is important because we
yeah.
can't, sometimes things can't be changed and we have to accept that that's how it is. But I always question. I'm always there trying to ask more. So let's
Yeah.
see.
Yes. Yeah, this is I think Ariane's here and she apparently benefited from IVIG, which is a medication that kind of works on the immune system, and I is a medication that I use all the time. But goodness, like everybody's so different. Not everybody needs IVIG. And people that do use it, like it's also like that's a big I use it a lot, but man, it's a big to do as well. Not only like to get it through insurance, and as you mentioned, you probably had a skin biopsy that can help, but yeah, this world of like chronic invisible stuff is really challenging. And it takes kind of an understanding not only of like diet and stress, but the immune system, the hormonal system, the nervous system, because it all plays together. Like, I think the fallacy of medical training was that we should be in our own little silos. And that
Yeah.
like and quickly I learned that like, what are we doing? Like
We
the nervous
can't.
system doesn't
Yeah.
exist on its own. It's not just a tube, right? It interacts with everything. And so
Yeah.
One
it
last
is
question about migraine with the R, if you just want to say something about that, Dr. Napany.
Sure. I am not seeing it right now. Was
Just
it in the chat?
oh, can I
Oh,
set you up for that
migraine
one?
with aura. Yeah. So
Can I set you
migraine
up for
with,
that one?
yeah, you can
So
set me up. I saw someone say asking a question, but I missed it.
and prediction for ischemia down the road.
So migraine with aura is it's the same pathophysiology, but we think it lends itself more to cortical spreading depression, which is basically like a wave going over your brain and spreading to activate different parts of the brain that are involved in vision, speech, motor activity. So it is the same, but it is a little bit unique and different. And in terms of the vascular risk, so we know migraine without aura does not pose a vascular risk. Migraine with aura, we think slightly increases the risk of stroke because it is working more on blood vessels. Again, the overall risk is low, but we do in those patients want to modify other stroke risk factors. For example, if they have high blood pressure or if they have high cholesterol or I think sleep apnea is a very overlooked one. So looking for sleep apnea, just making sure that we modify all the other risk factors to make the aura not as prominent, but also the less aura we have and we're able to treat it, the better we are for outcome in future.
Okay, we're going to let you both stop. It's Friday,
I
and
feel like we could talk literally
you've
forever.
got
I have like 8 questions in the chamber right now. It's not
we
like I'm
can
having
do
a tough
this
time biting my
again.
tongue right now.
So Miles for Migraine is going to be launching a new website soon that will bring all these resources under one HubSpot. We're working with multiple nonprofits and providers to bring more of these webinars like similar to this one next year. So please sign up for our newsletter on our website. And I want to thank both of you. You're both extremely intelligent and informative. And I really like talking to both of you. So thank you. Hopefully we can do this again.
I would love
Absolutely.
that. This was really
Thanks, guys.
fun. I feel like we could talk all day with both of you. So thank you.
Yeah, had a great time. Thank you so much.
Thanks, everyone.